Hello and welcome to the EduTalk series hosted by Biotone EduPartner Program, and massage industry experts. Though we've gotten through the worst of COVID, there are still challenges facing massage schools, students, and practicing therapists. The EduTalk series continues to support virtual learning and building massage community by connecting you with massage industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Tonight's expert is Doug Nelson, who began his massage career in 1977. He's the recent past president of the Massage Therapy Foundation and president of Bodywork Associates, a 3-clinic location in Champaign, Illinois. As an educator, Doug's taught over 13,000 continuing education hours in precision neuromuscular therapy through his institute, NMT Midwest. He's authored 3 books, is a recipient of numerous industry awards, and I haven't been able to talk him into it yet, but he's a cellist. Let's listen and learn as Doug shares the art of clinical decision-making by discussing the numerous series of decisions needed with every massage, asking by what criteria are treatment choices made? Do you practice by design or default? He'll explain how precision neuromuscular therapy is more than a technique or a modality, and how it centers on reflective practice and clinical problem solving. He'll explore how this approach deepens your appreciation, power, and promise of massage therapy to benefit you and your clients. Before I turn the talk over to Doug, I want to thank you again for joining us tonight. And please be sure video and your sound is muted. Best view is speaker view. And before I turn it over to Doug, he's asked to shake things up tonight and not hold back until the end of the presentation to submit questions via chat. He would like this to be live, interactive. Submit your questions when you have them, and he will answer them in real time. So, with that being said, Doug,
Thank you very much, Danielle. Thank you so much. And Danielle, I will actually use your help with the chat, if you would. So if you see something, feel free to kind of interrupt and let me know if there's a pertinent question that comes up, okay?
My favorite part, interrupting. Okay.
No, that would be great. And again, I really want this to be a conversation, more so than just a presentation. And I think of every session much the same way, instead of here's what I do, I hope you liked it, which is kind of like the model of I have a fabulous answer and I hope it matches your question. I'd really rather that this go in a direction that is meaningful and impactful for every one of you who've taken the time to be on the call. So from that, I'm going to share screen and we'll begin. All right. So.
All right. I'm going to bow out.
All right.
And for the people that just joined us, Doug is asking that this be an interactive, conversational via chat EduTalk tonight. So please please chat your questions to Doug and he'll answer them in real time. Thank you again for joining, and here you go, Doug.
All right, you got it. All right, so screen should be up now. So the presentation tonight is really focused on the art of clinical decision-making. And it's something that, the longer I do this, the more I think about that process, what that really means, and that and I think you'll see as we go through this tonight, how it's the decisions we make and why we make them that are really often the determinants between when we're successful and when we're not. And maybe the most important premise of all of this is that every therapeutic encounter is filled with hundreds of decisions that we make. And as I had alluded to earlier, do we make those decisions by design, or do we make those decisions by default? And I would submit that if we do it by design, it is a much richer experience for everyone involved, not only for the therapist, but also for the client, in that you never know. It's like a great conversation. It can go in ways that neither party anticipated in the beginning. And that's what's so amazing about it. Rather than and the same way I wanted to invite questions in this thing is, I know this presentation, right? If I do this, I mean, if I present this, in a way I've learned nothing, and it's a one-way direction. That leaves a lot to be desired in that you may be coming to this with some very specific questions or ways that you feel like you could benefit from this if only I would have addressed that. And again, doesn't that, you can tell my brain is always, I'm a clinician. I've spent so many years in the clinic. I think in that model all the time. But isn't that like what happens in a session? A client might leave the room and go, God, I wish they would have spent more time on my neck. And the therapist would think, I would have had I known that, right? But the client didn't say anything. So when we go back to these decisions, think about it. It's actually from the first, not only the first thing that you said, but how you greeted the client, what you chose to wear, what your waiting room looks like. I mean, these are all decisions that you make. And how intentional are they? Are they designed for the greatest impact, and for what reason? And again, as long as you have a clear, thought out methodology behind that, it's all good. But realize that every aspect of that relationship from the very beginning sets the tone, and really it could go in so many different ways. For instance, I've certainly witnessed both ends of the spectrum, even in the client greeting, where the therapist will come out and it's like, oh, are you my 3 o'clock? Well, that's an inviting thing, right? Or the therapist will genuinely, warmly receive that person. Like, I'm really thrilled to meet you, and can't wait. Those things make an enormous difference from the beginning. And it seems incredibly simple. It's simple and easy are not the same thing. As somebody told me once, telling the truth is very simple. Not always the easiest thing. So, I'm thinking about this as well. I remember one time being teaching through a school, and they had a student clinic, and they had an opening in the student clinic, and I got on the table. And I thought, this is awesome. And this student just kind of put her hands on my back and kind of nothing and I finally said, what are you doing? And she and then she said, I don't really know. It's like, and it kind of feels like that. She said, my instructor told me I'm just supposed to do this, but she said, I don't really. Guess what? It feels like that. It feels like you don't know what you're doing. Whereas, right, if you have a clear aspect of this and you have clear intent, you know what you're doing, why you're doing it, it feels totally different to the receiver of that communication. It's kind of like being flippant about hey, how you doing? Which really means, I don't really care what your answer is. Or, that African thing about, I see you, right? And a desire to really know what is happening with you. It just makes the experience so much richer. So in for all of us, certainly for me over the years, it's easy to get lost in the what of it all, like the technique and the, but the what, every what behind it should have a very, very clear why. And then you get to the how. But center to it all is the why are we doing this? And in some ways, that can be in the microcosm and in the macrocosm. As I've, wrote about recently, for people who are students beginning this journey, it's really important to remember why you began the journey in the first place, because there are going to be days that are going to be difficult. And when those days are difficult, it's really good to go back to that mission. What drove you to do this in the first place? Goals will fall by the wayside when the things get really difficult. But that mission, if you hold to that, will guide you for the rest of your career. And for me, that mission is that so many people struggle with soft tissue pain, and those people generally fall through the cracks of our healthcare system. And that's who I want to serve. And that has really served me well when things get really difficult. And I remember, this is way more than about me. This is much bigger than that. And it's kept me focused. So, so that's in the macrocosm. In the microcosm, for every technique you do, it's the why, the what, and then the how is the refinement and the skill building process. I'm very much, the arts are a big part of my life, as Donnell referred to. I still kind of like, am I really a cellist? I've been playing for 3 or 4 years, but I really love it, and I love the discipline of it. And that's why I have this image created of superimposing these two things, where the science of it all is really about letting us know what the possible tools and approaches to any specific approach might be. And those of you who know me know I'm very much into the science, and that's why my involvement with the Massage Therapy Foundation. But that leads us to the artistry and the mastery part of it, because in that, it's about the wisdom to know which approach to choose, when, and most importantly, why. So, there's knowledge, that's one thing. Wisdom is something different than that. And the longer I practice, the more I appreciate the aspect of wisdom, and it's all about the choosing. For me, in terms of the work itself, in terms of precision neuromuscular therapy, I'm nothing if not from the Midwest and Norwegian, which makes me incredibly pragmatic. I just want things to work. And what does that mean? In the case of therapy, what it means is changing the natural course of the client's condition. And again, we're looking at musculoskeletal dysfunction at this point. So effectiveness kind of equals, as you look up at the right side of the screen, achieved over desired, right? So we have the desired effect, like here's what I want the outcome to be. And then what did we achieve? And in the end, what we should be focused on is beating the natural course of events. In many cases, not all, but in many cases, time alone will make things better. I mean, I can think of a bunch of different conditions where that is true and many where that is not true. But again, the effectiveness of our approach, of the intervention, must be to shortcut that by a significant amount of time, and not just the duration, but also the comfort level during that process. So, we are married to the outcome. We are not married to the approach by which. So precision neuromuscular therapy is not married to this is the way we do things or this is the technique we use. It's not about that. It's really about just this outrageous focus on the goals. And so it's that clinical course over the natural course of events. That's what I mean by effectiveness. So there is no better feeling than knowing when someone comes to the office and they present with a host of different symptoms, many of which that, again, over 4 decades of work, I've seen what the natural course of events, and I'm familiar enough with the healthcare system and with my physician friends to know how these things might progress, to intervene, to intercede in that, and to make a difference is just one of the best feelings in the world. Oftentimes the client has no idea how much their life has been changed by this. All they know is, hey, cool, I'm better. And that's probably a good thing. But it's a great feeling to know that you've made a difference for someone else. If we look at the flow chart of this, the first and most important really is to ask questions. And we're going to explore that in just a few minutes. I'm going to walk through this kind of flow chart. And of course, once you gather information by multiple means, and that usually is what we see, what we hear, right, and what we feel, then you have to interpret that information. You have to decide, what does that all mean? There's no point in gathering information if you don't actually then interpret that information. And to interpret it means that you have to create some, in the light of that information, then this is what I think is going on, okay? And then intervention is quote, quote, therapy, right? So once you have that, here's what I think is happening based on the information I have. This is my response to that, which is our therapeutic endeavor. And then you reassess. If you intervene, you must also have an idea of what the expected outcomes of that intervention are. So for instance, if the client presents with restricted range of motion and rotation to the right, then it's like, okay, what's my hypothesis? There are multiple reasons, many, that could be true, that you could have restricted range to the right. So do I think it's a length problem? Do I think it's a strength problem? Do I think it's a facet inflammation? Those are just 3 that come to mind right away. And let's say I think it's the ipsilateral rotators on the opposite side that are not letting go. That's what I'm going to do. So I'm going to focus on those things. And then you do that, and then you reassess. And if the reassessment is, wow, that made almost no difference, okay, back to the drawing board, reassess everything, and then proceed forward, reassess again. And that doesn't happen at the end of the session. That happens, at least midway through. If you spend an hour going down the wrong road, you're just an hour away from where you're supposed to be. So don't wait for an hour to look at the GPS or the map, because that just means you're really lost. And by the way, if you have a fast car, you're just going to get farther lost, right? So the goal is to uplink to the satellite as often as possible. And that means a quick reassessment. Are we making progress? And lastly, I just wrote a little article about this, but it's called theranosis. It's a little bit of a play on the word prognosis, right? Which is, in this condition, here's where things are likely to go. Theranosis means, if we add therapy, what is likely to happen because of that? I should, if I have a really good model of understanding what's happening with, say, this person's neck, I should have a pretty good idea of what's going to happen after they leave the session. And this is something that I do with every client, in that I outline, here's what you are likely to expect. I will give it a 40% chance that there's probably another 30% chance that this might happen, and a 30% chance of this. This is what you can expect over the next 5 to 7 days. If that's not true, I want you to call me or email me or text me, but I need to hear from you probably within 4 days to know whether we're not on the right track or not. That's actually a really important point, because I've had people call me 3 days later and say, unbelievable. It's like everything is gone. And I know they think I'll be thrilled about that, but let's say it's a case where that is not at all what I expected. What that really means is that, you know, even a blind squirrel finds a nut once in a while. I just got lucky, which tells me just next to nothing about the next person who comes in with that particular condition. I'm not thrilled about those kinds of results, just in the same as if somebody has just awful, you know, response to that, then, you know, sometimes I'm blindsided by that as well. If I'm blindsided, it means that I really don't understand what's happening with them. And if, again, when the thing forward actually is pretty much what I predicted, then I feel like, yep, I have a good handle on this. And for the person, they feel much more comfortable with this. And it's the same reason, you know, I just had a medical procedure a little bit ago, and the doctor said, here's what you are likely to experience over the next, you know, 12 to 14 days. And you know what? Kind of everything they said was true. So when I experienced that, instead of freaking out thinking, oh my God, is this good? Is this bad? It's like, oh, this is what they said. Obviously, they know what they're doing. Obviously, I'm following this course. It's much more, it takes the stress away from, you know, the patient in this case, and from the client as well. So it's really, really important to do that. Yes, it's going to take some time for you to fully understand those things, and, you know, and sort of have the database in your head about those kinds of things. It's going to take some time for you to be able to do that.
Doug?
Yes.
We have a question, and I'd like to read it. It's from Cliff.
Sure.
I find that as a course of treatment is providing positive results, the client frequently quickly adapts to the new, improved sense of well-being and fails to recognize that actual progress has been made. Doug, what are your thoughts on the best ways to lead the client in their process and help them appreciate that the results are the direct results from the therapy?
Yeah, this is such a great question. And we'll touch base a little bit about this in a few minutes. But one of the things is to set benchmarks for people. So, and those have to do with functional attributes. So when I see someone, I want to know what makes it worse, what makes it better, how does this limit you? How does this affect your life? And I will write those things down. And there are also, like, the Back Disability Index. There are a bunch of different surveys that you can use. People often find those a little bit cumbersome, and I understand that. But many of these survey instruments maybe have, 15 questions. It's so interesting that when people come back and they say, well, it's good, I guess. And you think, so then I'll ask them questions like, well, you're still taking the Advil? Like, Advil? No. Are you doing this? Yeah. Well, wait a minute. That's not what you said before. And so that's why noting those things is really, really important, because I forgot who asked this question, but to their point, one of the great advantages of our human nervous system is our ability to adapt. It's also our worst enemy, because we just adapt to things. It's how we don't notice that things are getting better. Conversely, it's also how we don't notice things are getting worse until one day, you go to put on your coat and you think, oh my God, I can't bend my arm that way, right? Because you just haven't done it in a long time. So you don't notice that slowly, things are really heading in a really not good direction.
Doug, excuse me, there's some chats coming in.
Sure.
And Logan has said, even nothing is its own something. And hi, Doug. Are there any things you would have liked to do differently in your career with the wisdom that came later?
Yeah. Let me save that for later.
Okay.
Yeah, many actually. And I'll get to that in just a few minutes. Okay.
Yes.
All right. Back to this. Here we go. So, yeah. So one of the things about the whole question process is, for us, the questions really are intentional. We really do change what we do based on what the client reports and says in response to the questions. If I phrase it in a different way, I would just say this: if you're not going to do anything with the information you gather, don't ask the question. And every time I think about this, I think about this young man I saw. This was years ago, but I'll never forget it. And I was asking him some questions, and at one point he said, "Can we just cut the charade?" Like, say what? What? And he said, "Can we just cut the charade?" He said, "I've been to a bunch of different people. And a bunch of different practitioners, they all ask me these questions, and they pretty much do whatever the heck they were going to do anyway. So I've never seen you before. Why don't you just do what you do and let's see if it helps?" It's like, wow. In a way, what a really sad statement. And for him, actually, I'll never forget this. It's like, oh, you're going to love this, because now I'm going to keep asking questions, but every question I ask, I'm going to tell you what your answer means to me. If you say yes, it means this. If you say no, here's what that means to me. For him, this was just short of court-ordered punishment, and then we went through the process, and he was like, "Oh God, okay, whatever." And then there was a point where he was on the table for maybe 10 minutes or so, no talking. I'm just doing the work. And then he starts laughing. And I said to him, like, "Is this funny to you?" Like, "I'm Norwegian. We're not funny." Like, "What?" Yeah. And he said, "It's just amazing. This is actually the first time I remember anybody actually doing what I asked them to do." And I know he meant that as a compliment, but it's also a really sad statement. And he's right. So I would implore everybody, don't have your little battery of questions that you just ask people if you're not going to do something in response to their things. Like Donnell and I were talking a while ago, like, if a therapist says, "Where would you like work?" and then you say, "I want this, and then I want you to focus on this, and maybe this, and I don't care about these things," and then they just do like a formulaic whole body session anyway, it's like, why did you even ask me that, right? If you're not going to follow through and deliver on what I asked for. So it actually makes it worse. So ask, but be very clear. Make sure you respond to that. And I have always thought, for the last maybe 20 some years, I'm very interested in other professions because of their information gathering. There's so much to learn from our peers and other professions. And in the psych realm, one of my just studies that blew me away was this thing of, if you get feedback, real-time feedback, it increased effectiveness almost immediately by 65%. And I know about a bunch of you are on the call going, "Okay, cool. Yeah, but I do that." That's exactly what all the people in the study were saying. "I do that already." And the researchers were like, "Okay, cool. But we're going to videotape your psychotherapy session." "Oh yeah, cool." When they were videotaped, they were still not soliciting feedback from their clients. Even though they were videotaped about feedback, they still weren't doing it. And when the researchers then put in a more formal feedback solicitation, outcomes skyrocketed. So I remember reading this, and of course I said, "I already do that." And then I kind of put that into play, and it's like, yeah, how I know what isn't so. Actually, I could have been a lot better at that. I still could be a lot better at that. And one of the things that I would say, and I would hope that all of you would incorporate, is, here's what we do at my clinic. When someone comes in, and we see people with very specific problems, but still, it's, tell me how you want to structure this, where you want to begin, how much time do you want to spend on, these different areas, your neck, whatever it is. And then within the first 10 minutes, like, are you sure about that? Are you still sticking to that? Is that still what you want? And then certainly midway through and a few minutes from the end, it's like, we've got 7 or 8 minutes. What are you thinking? It's so important because the therapy session they have agency in the process. Instead of, geez, I didn't really like what they did. It's like, oh, I drove the bus. How can I not like what happened? Because I was the one driving the bus. It gives people a sense of empowerment and agency in the process. And outcomes will go up. Another way that I have incorporated doing that is I will do, like say it's a specific area in their infraspinatus. I will treat that, and then I will ask them, what feels more productive to you if I do it this way or I do it this way? Right? Because their nervous system knows what feels productive much more than I, as an outside, entity, could understand their nervous system. I let them choose. And what I can tell you is, it's all a philosophical approach to stuff. At some level, I don't care about that. I just care about the results. And the results, for me at least, went up massively by letting the person choose the approach. So something to consider anyway. And, in terms of a little bit to the earlier question, from the psych field, 2 clear things denote longer term success. And one of them is having success early. This is really important. So when I see someone, I want to make sure, like that person with the neck issue, there are some things that I would do before they got on the table, just with them seated. I would do a range of motion thing. I would have them so they clearly know the deficit they have in range. Then I would do a couple minutes of just work while they're seated and change that range. And they're thinking, oh my God, if that was the hors d'oeuvre, I can't wait for the entree. Are you kidding? Like in 2 minutes? And now you just set yourself up for an expectation of really good things to happen. And part of the thing about the questions also and deep listening is it creates and facilitates therapeutic alliance. And as you know, in the healthcare world, there are very few forces more powerful than that therapeutic alliance, that sense that this person understands me, that this person is connected and listening to me. So your deep listening to their and questions sets up therapeutic alliance. And it's really important. And another thing from the psych world, oh my goodness, the power of this is pretty amazing. It's clear that who does it is much more important than the technique the person does. In the psych world, much like ours, there are many different approaches, cognitive, behavioral, there's a whole list of them. And by the way, much like our own field, 20 years ago, there were about 40 some recognized approaches. Now there are more than 400. However, effectiveness hasn't really changed. So we just have more ways to get the same outcome. Things need to be better in terms of different. So, and the effect isn't small. The therapist, that criteria is somewhere between 6 and 9 times more important than the type of therapy done. And I think that's really true in our field as well. So I think for everybody, whatever technique that you do, just be insanely good at that technique. And also be an insanely good listener, and good things will happen. For me, one of the first questions that I think about, and again, I'm looking at musculoskeletal problems here, is because soft tissue, that domain is my, in a way, expertise, it's also my blind spot. And so I'm always protective to think, what makes me think that this person has a soft tissue problem. And that goes to this mechanical versus non-mechanical pain. So, and just to review, mechanical pain is pain that is made better or worse with movement or position. You know, if you have a, bone cancer, it doesn't particularly care which way you move. It just is unrelenting. And I know that there's some blurred lines with this, but I don't want to take the time now, but I have 3 cases in my career where I suspected this was non-mechanical, and it turned out to not only be non-mechanical, but not just life-threatening, but it took their life. So if that doesn't happen to you, your day is coming. So just keep that in the back of your mind. Always question first, what makes me think this is soft tissue related? And then if we're solving problems, okay, great. You have to define the problem. And what's the goal as defined by the client? And who decides what outcomes matter? So, in that person with restricted range of motion, for instance, I may care that, gosh, I'd really love to get you to 70 degrees of, right rotate. And they're like, they could care less about. What they really want to do is be able to look at the rear view mirror on their, car, whatever it is. That's why asking those questions, in what way has this impacted your life? And then are there ways that we can quantify that so that we know how things have changed? Really important. This is not an uncommon experience. I'm going to stop this share for just a moment and share again, because I need to do this. There we go. Okay, so tell me a little bit about what's going on and how I can help you today.
Well, I've got a lot of things going on. My neck's kind of painful. It hurts when I turn it this way, but I'm also having some pain in my back and my calf. I play softball, so that started kind of acting up this week, and I have plantar fasciitis in one of my feet. And so, there's just a lot of stuff going on. It's winter, I'm tense, I've been shoveling.
Okay.
So yeah.
Okay. And what brought you in today?
Oh, well, my husband got me a gift certificate, so I'm really excited to use it.
And for how long?
30 minutes.
Okay, great. Does this sound familiar? How many of us have had somebody come in with, 37 things, and then they have a 30-minute gift certificate? So again, how is it that you choose? There's no right answer to this, just to be clear. There's no right answer. I will tell you what I would do in a situation like this, knowing again that the slide I just showed you about therapeutic alliance and also early success, I would pick something that hopefully resonates with her, but something that I could make fairly immediate progress with, because that will inspire her then to come back and continue the process. If you try to pursue too many goals, what is that saying from Lao Tzu? He who chases 2 rabbits catches none. So these are difficult things, but my suggestion is look for the thing that you can make an immediate improvement, and that will inspire them to continue. And again, this is what I was mentioning earlier, always have some sort of benchmark to refer to. So a while ago, I had somebody come in the office and he said, I can't believe how much better I am. And I said, no, you're not. And he said, what? I said, nah, you're not better. He said, no, I'm better. It's like, no, you're not. Like, what do you mean I would know? Like, well, how do you know? Because I was able to do this and that and this and that. Like, oh, okay, I guess you're better then. So I made him list functionally all the things that he couldn't do, to just like, I get that you say you're better, but how do you know that? And when we say those things, it's almost always functional. So again, commit to finding functional ways, functional aspects of their life, And then there are always ways to quantify that. Even something as simple as when the person says, I stand over the sink to do the dishes and my lower back is killing me, then the question is, well, how long can you stand over the sink? Like, I'm telling you, 2 minutes and I'm done. So if the person comes back and then you ask them, did you do the dishes? Yeah, nobody else does them. How long did it take you? It took me 15 minutes. Did you have to stop? No. Okay, look at the difference about that, because here's what you told me the first time. That's why benchmarks are so important, and make sure that that becomes your focus, because if they are aware of them, that is the criteria which they will judge the effectiveness. So make sure that your criteria and their criteria are in concordance. And then once you have that sort of goal, you have to create a strategy, right, to be able to make those things happen. And I lay that out for people. Okay, based on what you say, here's my impression, here's what we're going to do. And then we execute it. And then at the very end of the session, I will tell them, okay, let's review this. Here's what you said. Remember that place? Yeah, I'm pretty sure you do. Okay, so that place, and then there was other, and these 4 things, we got to all of those, made a difference. And, you know, I like so much right now the changes that we have, but you know what? There are several aspects to this that we didn't really get to today. That's what session 2 is about. So we're going to look at these other things. And then on session 3, you lay all that out, and it's likely that they're going to follow through in that. It's been a long time since I remember somebody not following through on that second and third session. It's been a long time. In fact, in the last 5 years, 2 people. So I keep track of that stuff, nerd. So clinical reasoning, let's follow through on that process a little more. One thing that I think about in this is this a process problem or is this an event problem? Here's what I mean by this. And they're very different things. If it's an event problem, the person said it's this goofy thing that they did that presented with the symptom that they have. You know, I was walking the dog and then all of a sudden the squirrel ran across the thing and then the dog yanked my arm. Okay, that's a one-time thing. A process problem is like, I'll give you an example for a musician, and I see lots of musicians, it's an area of interest for me. If I'm seeing someone, how do I not know that the reason that they have hand and arm problems is the technique that they're doing? Less likely if it's a high level person, because hopefully they have a really excellent professor. But for instance, if it's a golfer or a tennis player, it's certainly possible that what they're doing is actually creating the problem, meaning that your treatment of the end result of it is going to be frustrating. So I always have to, in my head, think about which arena am I dealing with, process or event? Obviously, events are a lot easier. And as we go through this process, it's first you have the client presentation. And then, as I said earlier, you create this perception, you gather information, and then the initial concept is your idea of, okay, here's what I think is going on, and here's what I think is reasonable. I've actually borrowed this. For the last few years, I've taught at the University of Illinois Med School, and so sat in on some of their classes, and this is clinical reasoning for physicians as well. So my suggestion, theirs as well, but I really want you to think about this, and it's made a difference in my career and practice. Have more than one hypothesis. Don't, in the end, think, okay, I think it's this, and then pursue that one thing. I've been doing this for a long time, and I know the number of times I was really sure and really wrong. So it's more important to actually decide to pick 2 or 3 things, as long as they don't conflict with each other. That way, even if you're wrong, you're right. So it's a really important thing aspect to cover. Always, always, always have a plan B. In my head, like for instance, you know, I'm treating somebody's neck. I think to myself, and what else could explain that. So even if I seem to be on the right track, I'll stop what I'm doing and then say, okay, let's just pretend that none of that was true. What else would explain their symptoms? And I'll treat for that as well. Now, I understand that, if they're better, I don't really know which one. That's the downside to this. On the other hand, the client doesn't really care. So what they know is they're better.
Doug?
Yes.
Question. Can you elaborate on what conflicting hypothesis is?
Yeah. So sometimes, for instance, here's a good example of that. If you think the problem is a nerve issue and not a muscular issue, many times the treatments we would do for a muscle are completely contraindicated for what you would do if it was a neural issue. So you just want to make sure that the two strategies don't conflict with each other. Sometimes you run into things that are kind of diametrically opposed to each other. So find the middle ground where it would benefit both and have a negative effect on neither. Great question, actually. So in the clinical reasoning thing, it's what's the goal? And we just did this. Is there one right answer? Is there more than one right answer? And then these two kind of go together. What assumptions are you making? And what point of view are you taking? Like for instance, if you're a structural body worker, you may be thinking that a structure is the cause of their symptom. That's an assumption that you do not know. And again, that's a point of view. What if that wasn't true, right? And again, but what if there's evidence to point that in fact it is? Again, those are things you just have to process through along the way. And then, and again, based on what is your reasoning practice? If it's based on your experience and you've seen one or two people who've had this, that's really not enough to go on. Is there research literature to back this up? Are you connected with a group of therapists where you can bat these things around? Shared knowledge is really, really important. And then lastly, any implications or consequences. Like, for instance, there are consequences to not doing anything. For instance, when I talked about the mechanical versus non-mechanical pain, when I decided, I think this is a non-mechanical issue, I think you need to go see your physician, there would have been a cost for me for 3 or 4 weeks treating that person and delaying them actually getting medical care. In those cases, it was too late, but in other cases, certainly other cases, we were able to get them the care they need quickly. So these are all criteria, but by which we have to make decisions. To confirm or disconfirm things, I'm sorry, I'm actually going over a little bit. I just noticed the time, my goodness.
No problem.
Okay.
We're all listening.
Okay, all right. I've been thrown out other places, so just tell me, Dano. One of the ways, like for instance, with muscular things is to confirm or disconfirm. These are just some of the criteria. If the person presents with low back pain, for instance, and you suspect it might be the QL, by what criteria are you doing that? Does the QL have limited range of motion? Do you know how to specifically test it, specific to the QL? Is it tied to activity that would point it in that way? Is it painful on contraction? That's a really important thing. Are there structural reasons that would implicate the QL? Or in the heterotrophic arena, something like trigger point referrals, is it following a pattern that is known and understood along those lines? Multiple of these should be true. So seek to confirm and also disconfirm. And that's why assessment stuff is really important. But along those lines, it's incredibly important that you work to prove yourself wrong. I think people mistakenly have had this idea in research that the goal of research is to prove something correct. That's exactly what it's not. The goal is actually not to verify, but to falsify. So that's something that once I began to be a little more cognizant of the research world. I put that into my clinical practice. Again, when I'm seeing someone, if I feel like it's the gluteus minimus, or let's say medius, and then it's like, oh, when I do that, the client feels like, oh my gosh, that's it. Yes, that's it. And then what about this? Oh yes, that's it. And then I'll move off the medius into other tissue and other muscles. And what about this? So like, no. What about this? No. You were on target, a couple of minutes ago, but now you're like lost. Like, I'm not as lost as you think. I'm just trying to see if it's exactly what I thought, or whether everything in that area is sensitive, because if everything is it, that's not it. So, once I think I know what it is, I go to pretty great lengths to try to prove myself wrong. And if I can't, I'm probably on the right track.
Doug,
Yes.
excuse me, could you go back 2 slides? There was a question that came in that what was number 4 on previous slide for QL?
So there's limited range, tied to activity, painful contraction, structural asymmetry, and a known trigger point referral.
And what I'd like to mention, since we just had this question, is that tomorrow in a follow-up email, we'll include Doug's PowerPoint presentation, so that along with a link to the recording tonight, so that you can, again, listen and review Doug's presentation tonight. So, all right, Doug, do you want to finish, go back to where we left off? Great.
Sure. Yep. Sorry. So, what I've noticed in doing this for years is, especially in the teaching thing, and again, 13,000 hours of continuing ed, those who struggle are the people who succeed. The therapists who struggle a little bit with confidence are the ones who, in the end, do better than people who are their confidence actually exceeds their competence, because then they just don't end up being learners. So the rethinking cycle is something I've spent a lot of time with over the last really a little while. Real life in the clinic is all about humility. The clinic will humble you, and it's why I spend so much time there. And I know people tell me I should do other stuff and teach more and be on social media and whatever. And I'm happiest being in the clinic. And honestly, it's so humbling, because people come in with real issues, and it's a real struggle, right? They wouldn't call them problems if this was easy. And honestly, that in my life certainly has created doubt, like, oh my gosh, can I help this person, whatever. But that doubt, it can be debilitating, or it can turn up your curiosity. It's like, well, then I need to get the knowledge that I need to help that person. I need skill acquisition. I need to go out and get the skills I need to make a difference with this, or to know what I need to know about that condition. Most of the breakthroughs in my career have all come by the grace of many of these clients that I've really struggled with. Because in reality, the people that I have treated and it goes incredibly smoothly, it's good for them. I learned nothing. All the clients that I struggle with, those are the ones that I've learned the most. So humility leads to doubt, which leads to curiosity, which leads to discovery, and good things will happen. So if you're that person out there and you struggle with your confidence, and you kind of shy away from the problem solving thing because you feel like you're very vulnerable, and well, welcome to my world. But that world is rich, and that's where all the learning happens, right? And you know what? I think this is a good place to end, actually. So let me just end there and say thank you to everybody. And again, I'm so sorry that this went on longer than we planned. But if there is any questions now, I'd be happy to do that and or finish up. So, and I'm going to stop the share.
Well, There have been a lot of thank yous. One comment that they're happy that they'll be able to rewatch this and have the PowerPoint to review as well.
Yeah.
It was a lot of information to absorb, and you know, it was really fascinating. And I'm a lay person. I'm the one that you'd be treating on your table. And to understand this process also helps me understand how I can better guide you.
Yeah, absolutely.
And the type of communication I should be giving my therapist. And you know, recently I had a new therapist, and I said, okay, tell me what's going on when you get to a place, because I can tell what's happening on the inside, but I want to know what you're coming across on the outside.
Exactly. Exactly. And I think part of that so important, Donnell, is that people don't realize how vital their communication is. That is just, it's so important. And again, if we don't share that with them, I think sometimes, Donnell, really good therapists, it actually works against them a little bit, in that the client will say, you just seem to know where things are. And as soon as I hear that, I'm like, whoa, 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 whoa. I know where the likely suspects are. I need you to help dial me in. I need you to tell me if this is relevant, if, you know, to what you feel. And I need you to tell me if this is a productive way to deal with it. Only you can know that. I cannot. I could not know that. I cannot know what you feel. Just the same as for those of you who are still on this presentation, I don't know what you took away from this, right? I know the spirit, I put it out. I know the content. I don't know how you receive it. You know, that's something different. I could only know that in a conversation with you personally. Does that make sense?
Thank you. Yes. I would like to go back to a question that came in earlier. Are there any things you would have liked to do differently in your career with the wisdom that came later?
Yeah, I think, yeah, whew, how's that for an answer? Yeah, I followed that sort of Dunning-Kruger model of, I went from cluelessness to a little bit of bravado, which I'm horrified now when I look back at that. Like, I think at some point in my career, the vulnerability of being in the clinic and feeling like I didn't know scared me. And in some ways, I wish I would have just embraced that, instead of, my response to that was almost like doubling down on the things that I knew, and my confidence level actually exceeded my abilities. And so at some point, I just became much more comfortable with the fact that there's so much I do not know. And I feel that today. I mean, there are probably people on this, you know, call who know far more about aspects of, you know, their work or the field or whatever than I would know. And that's wonderful. We can learn from each other. It's, I just didn't embrace that vulnerability in the way that I now savor it. And I see that that is a portal through which amazing things can happen. So it's embarrassing in one way to reveal that, but that's the answer.
That's the humility. Logan said, client education, your next class.
Yeah, it's really, it's so important. And I think, yeah, you just can't understate how important people need to understand what their role in this process is and how much their input is needed, as we were talking about earlier. So it's a partnership, and it goes a little bit to a distinction. Maybe it's a little more in my head because of the era that I came in, but body work versus massage therapy. You know, massage therapy, you know, massage in some ways is seen a little bit more like a service you can purchase. Body work is more like a shared experience, a learning process. It implies that there's this communication, this shared experience between the therapist and and the client. And I really come from that model and find myself more and more returning to that in multiple ways, probably because one of my early first teachers was Moshe Feldenkrais, and decades later, I'm just beginning to get a clue what Moshe was trying to tell me. So,
well, Michelle said, Michelle Dragas, you're still such a great teacher and a big part of my practice, going back to when you TA'd for Paul St. John. So good to see you are still growing and sharing. A great big thank you. And others have thanked you for your transparency and your wealth of knowledge, and very affirming and encouraging. So, and so good to listen to you again.
That's great. Well, again, if there's one point, it is, if you feel the vulnerability and whatever, the learning is in the struggle. So embrace the struggle, because that's where
we launched the EduTalk author series, and these are book reviews and textbook reviews with the authors in quick Zoom format. So search YouTube out for EduTalk author series. We've had Cherise Onemo, Jody Scholes, Nikki Kenward from the UK, who's an Upledger therapist, and many more. So join us for both the EduTalk series and on YouTube, the EduTalk author series. Thank you, everyone. Thank you for participating, and good night. Thank you, Doug.
Thank you, Donnell. Thank you for everything.
All right, take care.